Thanks very much to the organisers for inviting me to speak on these interesting topics. I'm going to do my best to squeeze as much as I can into 20 minutes. So I'll talk about some of the key research in this area and also some of the research I've done as part of my PhD. So here are my disclosures. I received funding from Cambridge Weight Plan for my PhD, and I also work on the direct trial. Sorry, I'm just getting to grips here with the slide transitions. So to start with some background here, Tony's presented some rather more promising findings from recent trials, the direct study and the diet trial. But this slide here and decades of research really has shown that we're very able to help people to lose weight, but the real struggle lies in helping people to maintain weight losses over time. And what you can see from this slide is that people on a low energy diet were able to lose 15% body weight over a 10-week period. But over a 3-year period, two-thirds of that weight loss was regained. And the nature of the dietary intervention here is not the point. The point here is that regardless of dietary intervention, this is the pattern that's typically followed when after people have lost weight. And I want to draw the distinction here between weight regain after successful weight loss and average adult weight gain, which is somewhere between 0.3 kilos and half a kilo per year. So there's something different going on when people have lost weight intentionally with a diet versus primary weight gain in the development of obesity. So the question then becomes really is, why is preventing weight regain so difficult? Now, we talk about weight loss maintenance, but really it's probably more of an academic construct than anything else. It's really about how do we limit the regain of weight after successful weight loss. And this was something that I investigated from different perspectives during my PhD. I think it's important to acknowledge, before I start talking about the sort of physiological and behavioural factors, is that body mass index and obesity and thinness is very strongly influenced by genetics, and it's really true to say that obesity is unlikely to develop in an environment with a limited calorie availability. So in the current obesogenic environment, human beings have evolved to cope with food scarcity, and we're not quite so well served when it comes to dealing with an abundance of food. So it's really the interaction between our genes and our environment that explains the global rise in obesity. And it's this that we need to keep in mind, and how these factors influence with the changes in physiology that occur with weight loss and how this impacts on our behavior. So it's a whole interacting picture. And I think George Bray called it about right when he said that genetics loads the gun, but environment pulls the trigger. So in terms of the physiological regulation of energy balance, what we know is that there's dozens of hormones regulating appetite. And these are received from the periphery, from the gastrointestinal tract, and from adipose tissue. And they're processed within the brain and translated into feelings of hunger and satiety. And in people with obesity, when they're compared with people of a healthy weight, they display what we might say is a dysregulated gut hormone response. So what I mean by that is satiety hormones, so telling the brain that you're feeling full, such as PYY and GLP-1, are reduced in the fasting and post-meal state in people with obesity. And the hunger stimulating hormone ghrelin, there's a reduced suppression of that after meals in people with obesity also when compared to people of a healthy weight. So this has clear implications here for eating behavior. We also know that in people with obesity, they display a greater activation of areas of the brain related to pleasure and reward in response to high calorie food cues, and reduced activation of areas of the brain relating to restraint and control. So when you think about the environment that we currently live in, where we really have ever-present opportunities to eat. This has serious implications for managing body weight, and we need to look at things in this regard and have more understanding towards the difficulties that some people will have in managing their weight in current conditions. So what happens when we put people on a diet? Well, this is a landmark study from the Prehito group in Australia, which shows that after a 13.5% body weight loss, the hunger stimulating hormone ghrelin goes up over time, and satiety hormones go down over time. And these are both in the fasting state and postprandially. And when people were asked about how hungry they felt or their desire to eat, these sensations, so hunger was increased after weight loss, and this was sustained over time, and the desire to eat also was increased from baseline values and sustained over time. And this really gives pause for thought in terms of, you know, how we perceive the voluntary control of food intake. So the next question becomes then, well, what happens if you can change the background physiology with a drug? So this is data from the semaglutide trial, which was recently published in the New England Journal of Medicine. Now, semaglutide is a GLP-1 analog, so something that helps to reduce appetite. And this was a randomized controlled trial where both groups received a lifestyle intervention, but one group received placebo and the other group received the semaglutide. Neither group knew what they were receiving. And you can see clear marked differences in weight loss. So in the placebo group, the weight losses were 2.5% body weight versus 15% in the group who received semaglutide. So if you can change the background physiology, you can change appetite and you can change behavior. Let's be clear on this. People who receive semaglutide don't become better at meal planning and calorie counting. They're able to change their behavior as a result of reduced appetite. And just to further expand on these findings, which are potentially a game changer in obesity treatment, more than a third of people lost more than 20% of body weight. More than half of people lost 15% body weight or more. So we need to await longer term results. It's quite clear that if this drug is stopped at this point, people will regain weight. So we need safety data showing that these drugs are tolerable over the long term. On the other side of the energy balance equation, we can think about changes in energy expenditure, so how many calories people are burning. So this was another really elegant study, 25 years old now, by the Libel group from the Rockefeller in New York. And what they showed was, in really very tightly regulated conditions, was that when people lose 10% body weight, their energy expenditure reduces by around 15% more than what you would predict for the change in body weight. So we know for sure, and have done for a long time, that when somebody loses weight, their metabolic requirements go down just as a function of reduced body mass. That's common sense. So for example, a bigger person requires more calories to maintain their weight than a smaller person. What we're talking about here is a reduction in metabolism above and beyond what you would expect for the change in metabolic mass. Now, and a key point to say here is that this adaptation does not seem to worsen with greater weight loss. So this has invoked a weight loss of 10%, and it doesn't seem to get worse when you lose more weight. It's important to say here, with as most people will be aware, with in the field of obesity and nutrition, there's controversy. So not everybody agrees with this perspective. There are differences in methodologies used and differences in perspectives. But it's quite clear to my mind, based on looking at the sum of the data, is that this is an impediment to long-term weight loss maintenance. And another trial speaking to this was the Biggest Loser study, led by Kevin Hall's group, and it was front page news on the New York Times. And what basically it was saying was that the reduction in metabolic rate beyond what you would expect persists for several years after the weight loss, and even in the context of weight regain. So to summarize, some of the key physiological points here. Diet-induced weight loss activates compensatory changes in biological mechanisms that favour weight regain. And so what I mean by this is we have an increase in hormones regulating hunger and a reduction in hormones promoting satiety. And also reductions in energy expenditure beyond what we would expect for the change in body weight. Go back. Now, this is not to say all hope is lost here. We're not just a bag of genes and physiology, and we have no control over our own behaviour. This is what differentiates humans from the rest of the animal kingdom. So when we look at the Foresight report and the diagram that they produced, which showed over 100 variables affecting energy balance, there are many targets for lifestyle modification at the individual level and for altering thinking patterns and so forth, so that we can direct our thoughts and our motives towards changes in eating behaviours. When we think about some of the behavioural interventions we can use in this regard, and what are the most effective ways to do this, it's actually been known for an awful long time that very low energy diets are associated with better initial weight losses and better long-term weight loss maintenance. And this is a systematic review from 2001. And the figure here, you can see the line at the top is people who went on to very low calorie diets, so diets of 800 calories or less. And the average weight loss at 1 year is around 17 kilos, and the maintained weight loss at 5 years around 7 kilos. And this is contrasted with a weight loss of an average of 6 kilos and a maintenance of around 2 kilos in people who are going on to what you might call more sort of healthy moderate energy restricted balanced diets. So this has been known for an awful long time, and that's possibly contrary to popular opinion. Why does this happen? Well, Tony's touched on it already. We've often found that when people who are on total diet replacement programs, certainly, is that they don't feel hungry. So part of this may be mediated by physiological factors, so that the rise in ghrelin is not so pronounced, and that we think is due to ketosis, which occurs when restricting carbohydrate and energy intake. So you're able to increase the energy deficit without increasing hunger. Of course, that's a very good thing when you're trying to support people in losing weight. It also obviously facilitates portion control compared to food-based diets. So people don't need to count calories, they don't need to plan food, they don't need to cook and prepare and do all of these things that make losing weight challenging. And it's convenient. So people have busy lives, and you know, for some people, meal replacements are a very helpful way to lose weight. The other thing is that people, relatively speaking, experience faster rates of weight loss, which is a rapid reward for behaviour change compared to more modest energy restricted diets. So we know that people find it very disheartening when they feel like they're making a lot of changes to their diet, they're exercising a lot more, they get on the scales and they lose half a pound or something like that, and it can be demoralising, and people often give up for that reason. In terms of academic research, we tend to present data as averages, and this conceals a lot of the individual variability that we see. This is an unpublished figure from the DIRECT trial, which shows both the controls and the interventions, the weight losses for each individual. So each dot, each circle indicates one person. And when we look at the intervention group, yeah, the mean weight loss was 10 kilos, but this actually represents very few people. What you can see, of course, is that there's some people that don't do quite so well as that. And you also have a significant proportion of people losing somewhere between 10 and 20 kilos. So I think it's always really important to keep in mind the individual variation when we talk about mean outcomes. When we think about who did best, then it appears that men seem to do relatively better than females when using a total diet replacement led program. And this was at both 12 and 24 months. Men had significantly higher rates of remission, and this was explained by greater weight losses. People who have higher anxiety and depression scores tend to lose less weight, and we know, of course, that engaging with lifestyle change programs is more difficult when life is more difficult. And again, as Tony alluded to earlier on, early weight loss is a strong and robust predictor of long-term weight loss maintenance. And we found that weight losses within the first 4 weeks of direct were strong predictors of remission at 12 and 24 months, which of course is all driven by weight change. But overall, we lack good pre-treatment predictors that can assist us in identifying people who are most likely to succeed or not succeed. In terms of what's the best approach to weight loss maintenance? Well, we know that diet is king when it comes to weight loss, but in terms of weight loss maintenance, the queen, perhaps, as you might say, in terms of exercise, makes a good union with the diet component, because we know, it's well known that a combination of diet and physical activity is the most effective way to maintain weight loss in the long term, and exercise has become a strong and robust predictor of weight loss maintenance. Now, if the effects of exercise were driven entirely by increasing energy expenditure, it would be easy to understand, but we think that exercise also has beneficial effects on reducing hormones such as ghrelin, which stimulate appetite, as I said earlier, and in terms of increasing satiety peptides. We also know that extending support is also associated with a reduction in weight regain. So when you think about the direct trial and the diadem trials, they've taken really what's been known about weight loss and weight loss maintenance and put them together into interventions. So you could say that at the current time, state-of-the-art weight loss maintenance is rapid early weight loss, extended support with an emphasis on physical activity. And I just briefly want to just highlight some of the differences between direct and diadem. I think it's interesting to see that diadem had 12 kilogram weight loss at 12 months versus the average of 10 kilograms in direct. We don't know the long-term data. We await the 2-year outcome data from that trial. But to speculate on some of the reasons why that might be, I think that it's interesting to see that 70% of the population were male in the diadem trial. They had an extended food reintroduction period after the total diet replacement, so that ran for 3 months. So there was longer on a partial meal replacement plan, and there was initial emphasis on a lower carbohydrate approach during food reintroduction. And it might be that these combinations of factors may induce better weight loss maintenance, but we have to wait and see. In direct, we recognize that weight regain would occur, and we built in what we called rescue plans. So that meant that when people regained a certain amount of weight, they could go back onto total diet replacement or food reintroduction. And my colleague Naomi Brosnahan published a paper recently which shows that for a proportion of people, this is very helpful in terms of losing small amounts of weight that's been regained. In terms of weight loss maintenance, I think it's really quite clear from all of the data that there's no one-size-fits-all approach here. There's lots of debates about the most effective dietary intervention, but I think for a long-term lifestyle change, it's about tailoring things to the individual. Most people know what they should or shouldn't be doing. In terms of actually putting that into practice, that doesn't always happen, and we need to think really about how we improve intervention adherence. We can do this by delving into the psychological literature, so a systematic review investigating theoretical explanations for behaviour change maintenance found 5 overarching themes which are important. So I've listed them all there. I won't go through them all, but essentially, if people are satisfied with the outcomes they achieved, if they enjoy what they do, if they're able to self-regulate behavior and develop strategies to cope with barriers, if they're able to develop routines that become more habitual over time, they're more likely to maintain their behaviors. Another crucial aspect here is about having plentiful psychological resources. So being able to cope with stress and being able to cope with life difficulties is important. And of course, we know that having a supportive environment also is crucial. A really useful systematic review. It also gives us some indication of how to improve adherence, because when we talk to people about what works for them and what doesn't, we get the lived experience. So our outcomes in, for example, in direct, we present mean outcomes. It doesn't tell us how people changed and how they managed to do it. And the key theme that came out of this systematic review of weight loss maintenance related qualitative research was that making behaviour changes required for weight loss maintenance generates a psychological tension due to the need to override existing habits and the incompatibility of new behaviours with the fulfilment of psychological needs. Now, what this says to me is that there is a conflict between eating enjoyment and flexibility and the goal of weight control. So you better make sure that what you're doing in the long term is something that you enjoy. I conducted a qualitative research study as part of my my PhD, and what we found briefly was, on average, at 6 months, people lost 15% body weight, and about 9% weight loss was maintained out to 2 years. Now, there was no single experience that was common to everyone, but two key things came through to me. One was that after weight loss at around the 6-month mark, people underestimated the potential for future weight regain, and they overestimated their ability to cope with future difficulties when they're highly motivated at a point of major weight loss. So people find it difficult to anticipate future barriers, and this, I think, seems to get in the way of coping planning. The thing is that the other thing was that the potential for regain remained over time, and this is mainly as a result of emotion-triggered eating to alleviate stress and negative mood. And I think we haven't quite got into focus just yet within behaviour change interventions, this need to address the emotional drivers that overwhelm dietary restraint in periods of stress and low mood. So in terms of strategies that we can use to counter some of the physiological responses to weight loss that I described, I think first and foremost, people with obesity need to be better informed of the challenges of weight loss maintenance. I think people generally grasp that, but actually it's but understanding the biological mechanisms that are promoting weight regain. If people understand this, they're maybe more likely to engage with some of the advice that comes alongside that. So if we are able to focus on low energy dense foods like the meal shown in this picture here, we're able to increase meal size and reduce hunger and energy intake by focusing on foods that are low in calories. So vegetables and fruits and whole grains and legumes, these types of things, we eat with our eyes. So, this looks like a big portion of food, but actually we're very good bang for your buck in terms of calories, you might say. We know that higher protein meals are more satiating, and a higher protein diet helps to attenuate postprandial rises in ghrelin, and by upregulating satiety hormones such as GLP-1 and PYY, so to enhance fullness. Physical activity, as I mentioned, also has effects far beyond the energy expenditure components. So it also helps to acutely suppress the hunger stimulating ghrelin and increases GLP-1 and PYY without compensatory eating. Mentioned the gut hormone therapy. I think that's really where treatment has to go in the long term. For long-term weight loss maintenance, we can help people to lose weight with formula diets, for example, but I think that we're still going to need help in the longer term for maintenance. And in addition to that, what I previously mentioned was about interventions being better at addressing the emotional drivers of weight regain. So to summarize, there's no single mechanism which explains weight loss maintenance, but increases in appetite and adaptive reductions in energy expenditure may undermine the self-regulation of eating and the efforts to prevent weight regain. Diet and lifestyle behavior fluctuate in response to life, and this is normal. Weight regain is normal. And I think we need to convey these messages sensitively to people with obesity so that we reduce shame concerning weight regain, and we leave the door open for people to remain engaged in treatment. And this type of attitude is going to help to facilitate coping planning and to prepare people in order to better maximize weight loss maintenance. I've mentioned a couple of times regarding interventions with greater emphasis on developing the skills to address emotional eating. And this may require training for healthcare professionals and counsellors. And I think my final thought is concerning a question really, is behavioural maintenance actually realistic for most people? The data would suggest otherwise. And this is just a speculative point really. I think that most of the things that we do in life, we do in phases. So there's very few things that we start and we maintain for life. And I think in many ways, weight management is a little bit like that. So I think we need to maximize the potential for weight loss when people are interested and motivated to do that, and seek to minimize weight regain when it's not people's main focus, but keep that door open to return and to re-engage and to retry.